So we're always going to identify our patient by agency protocol. We are also going to follow state and federal regulations. We are going to abide by standard procedures or standard precautions, make sure that we're wearing gloves, hand hygiene. We are going to ensure patient safety and privacy, as well as promote good body mechanics. For inserting a nasogastric or nasoenteric tube, we are going to be preparing the tubing. First of all, so if we are dealing with a plastic tubing, we are going to make sure to set it in a basin of warm water for 10 minutes. And then if we are dealing with a rubber tubing, then we are going to be setting it in a basin of cold water for 10 minutes. So for a small bore tube, we are going to be inserting either the stylet or guide wire into its proper position according to agency policy. If it is already inserted into the tubing, we will not be removing it until after verification of placement of the tubing by x-ray. After removal, we are not going to be reinserting it. So after selection of our tubing, we are going to be preparing our other supplies. Our other supplies are going to be including tape, a 60 millimeter Tommy syringe, water, soluble lubrication. We're going to need a stethoscope, a tongue depressor, our pen light, a rubber band, safety pin, water, a cup of water with a straw, and pH strips. Before starting this procedure, we are going to be making sure that our patient is properly positioned. So normal positioning for this procedure is high Fowler's position. If a person is comatose, then we are going to have them in semi-Fowler's, and we are going to ask a coworker to help position the patient's head during the procedure. If they are combative, we are going to also ask for assistance from another coworker. Then we're going to be assessing for nasal patency. We are also going to be asking the patient if they've ever had any nasal or facial surgery or reconstruction. We're going to ask them if they have a deviated septum and if they've ever had an NG tube inserted before. So when measuring tubing, we are going to start at the tip of the nose to the earlobe, and then from the earlobe to the xiphoid process. And then we are going to make sure that we are marking it with our tape. And then for an NE tube, we are going to add 4 more inches onto the measurement. So if we are right-handed, we are going to be standing at the patient's right side. If we are left-handed, we're going to be standing on the left side. We are going to prepare the fixation device, or we are going to cut about 4 inches of tape, and we would split it about halfway down the middle, lengthwise. We're going to make sure that we are giving our patient water with a straw. If they are able to swallow, we are also going to grab our Tommy wrench. Is it Tommy or Tommy? Tommy wrench. And we are going to fill it with 5 to 30 milliliters of air. And there's our 30 milliliters of air. So we are going to take our tubing and we're going to wrap it tightly around our fingers, about 5 to 6 inches, and then release. That helps with the flexibility of insertion. About 4 inches down with water soluble lubricant. And we are going to ask the patient to hyperextend their neck up so that their neck is extended back. So we are going to be holding the tube at the end of the lubricated section. When inserting, we're going to be inserting slowly. We are going to make sure that we are inserting with the tube section part facing down. We're going to insert on the nasal floor, laterally towards the septum. The tube reaches the nasopharynx. Then we're going to use a little or slight pressure, not forcible pressure, but just a little slight pressure. We're going to make sure that we are providing our patient with tissues in case of eye watering. We are going to go past the nasopharynx, and we are going to be aiming towards the opposite nostril. After that, we are going to provide our patient a break. We are also going to be explaining the next step of the procedure, which is going to include the swallowing of the water that I provided him with previously. And I'm going to direct my patient to flex her neck down and then take a sip of water. So we are going to be rotating 100 degrees while we instruct the patient to take a sip of water. We're going to be advancing the tube 2 to 4 inches every time they take a sip until we have reached the pre-measured amount. And then we are going, if the patient does gag, we are going to stop for a minute, ask him to take a deep breath, ask him to take a sip of water. Gagging continues, then we are going to use the tongue blade and the pen light to assess and make sure that the tubing is in the right placement. If the tubing is coiled in the patient's back of their throat, if they are coughing and gagging excessively, or they develop respiratory distress, we then will remove the tubing, give them a break, and then we would try the procedure again. Other than the initial x-ray that our patient will be given before any kind of administration through the tubing is performed, there's a few bedside verifications of placement that we can also do. So number one, of course, is inspecting the back of the pharynx to make sure that there's a presence, or if there's a presence of the tube coiling. We can also inspect the pH, so we can aspirate stomach contents and check with our pH strips. So gastric contents usually are between 1 to 5.5. Another method would be inserting air and auscultating the abdomen to hear which sound. We are also going to ask the patient to speak. Once we think that there is a proper placement of the tubing, we have checked and made sure that the tubing is placed according to our measurement. We can then apply our tape. So we would use a skin adhesive before we started, or before we applied tape. We'd allow it to dry. So I'm using my 4-inch tape with the long split down the middle. I'm going to be placing the tape around the tubing here, and then I am going to take one of the sides of my tape, and I'm going to apply it on one side of the nostril, and then I'm going to take my other one and I'm going to apply it to the other side, and we are going to ensure that it is in place. We can also use a fixation device. So in that case, we would take the whiter part of it, and it would go over the bridge of the nose. Then we would position the connector where the tubing exits the nose. We are going to slip knot a rubber band to the tubing We are going to secure a safety pin to the gown of the patient, and then we are going to wrap our rubber band securely, or put our rubber band securely in our safety pin. After we have attached the tubing with a safety pin or rubber band, we are going to ensure proper placement of the tubing by x-ray confirmation. We can either clamp it or connect it to the suctioning. We're going to be placing it like this. And this is the air vent. And then we would elevate their head or the bed 30 degrees. We would turn on our suctioning to the proper amount. We are going to make sure that we have the measurement marked where the tubing is placed. We are also going to measure the tubing to the connector and record that as well. And then we are going to perform proper maintenance on the tubing according to agency policy. For our initial equipment setup, we are going to locate a canister. We're going to make sure that we are placing it in our suction device here. We're going to make sure that our suction device is plugged in. We are going then to attach our tubes here. So the shorter one's going to go like this. And the longer one going to go right here. So after verifying that our tubing is in place, we're going to make sure that it's secured to the gown. We are going to apply it to our suctioning device. We are going to then turn on the suctioning device to the prescribed amount. If our Salem pump tubing, which this would be one, doesn't have a vent at the end, we are going to be putting 10 to 20 milliliters of air in it. And we will be monitoring the secretions that come into the suction container. In our suction container, we are going to make sure that we turn off the suction container source. We are then making sure that our nasogastric tubing is clamped off. And then we are going to remove all the tubing from the canister. We are going to also have a like a graduated cylinder, and we're going to go ahead and empty the secretions out of that. We are going to be knowing the consistency, the color, the amount. We're going to be measuring the amount. We are going to also be noting the odor. After that, we are going to be disposing of the secretions according to agency protocol. When we are done, we are going to make sure that we put it back and our conductions are the way we had it before. We are going to be then turning our suctioning on, making sure that we are unclamping the nasogastric tube. Also going to be assessing for patency of the tubing. We are going to make sure that it is suctioning properly, make sure that everything is disposed of properly, take our gloves off and wash our hands. For irrigation of the nasogastric tubing, we are going to make sure that our patient has a linen protector underneath them. So we're ensuring the placement of the tubing. So of course we'll look at the measurement, our measurement, We are also going to be inserting air and auscultating for that whoosh sound. We are also going to be checking the pH balance of the gastric secretions. Again, that is between 1 to 5.5. And then we are going to be filling our syringe with 10 to 20 milliliters of either normal saline or tap water. Next thing we're going to do is either clamp or turn off the stopcock. Going then to be holding the suctioning tubing up so then all the secretions can filter into our canister. We can either place it on the patient's pad, or we can put it back on our suctioning machine, hanging it over our suction machine. After that, we can then unclamp it, and then we are going to be unhooking it from our safety pin. And then we can then go ahead and put in our solution. So here I have 20 milliliters of solution. Making sure not to insert fluid into the air vent. We are going to be inserting our solution very slowly without forcing it. So we are going to be inserting, and then we are going to be putting the G-tube, pointing it downward, or I should say lowering the end of it. And then we are going to be withdrawing fluid, and then we are going to be performing the same thing and inserting fluid back up into the tubing until the fluid flows freely. So when we're done, we're going to go ahead and remove it. When we're suctioning, we are connecting the tubing to the suctioning. We are going to be using this little adapter to connect it into the suctioning. This is the air filter or air vent. We are pinning our rubber band back to our patient's safety pin on their gown. We are going to make sure that we are providing comfort measures and that we are making sure that we are disposing of everything properly, and we take off our gloves and wash our hands. Okay, for nasogastric removal, we are going to be checking the client's history, confirming that the order is in place for removal. If we are removing a feeding tube, then we are going to wait 30 minutes after the last feeding to remove it. We are going to make sure that our patient is sitting upright in high Fowler's position, make sure that we are draping the patient with a linen saver. We want to make sure that we have a plastic bag for disposal. First thing we're going to do is we are going to turn off our suctioning device here. We are going then to disconnect the tubing. We are always going to be telling our patient what we are going to be doing and explaining the procedure, explaining some of the symptoms like gagging or uncomfortness while removal. So after we have disconnected the tubing, we are going to be flushing out the tubing with 10 milliliters of air or normal saline solution. We're going to be unpinning our tubing from our patient's gown. We're going to be removing the tape. We can use the adhesive remover to remove the tape. If we are right-handed, we're going to be on the patient's right hand side and opposite for the left-hand side. We're going to make sure that we are either clamping or pinching our tubing. And we are going to also be holding and preparing our towel or washcloth for the removal of the tubing. Quickly and smoothly, we're going to be removing the tubing from the patient's nose. We are going to be clamping it in a towel, and then placing it in our bag that we had available. If the patient isn't able to do so, we are going to provide mouth care, nasal care. We are also going to be measuring the output of the secretions. We are going to be noting the characteristics of our secretions. And of course, we're going to make sure that everything is disposed of properly. Our gloves are removed and our hands are washed. Providing comfort measures for somebody with a nasogastric or nasoentry tube. We are going to make sure that we, of course, are donning gloves, providing oral hygiene. We are going to make sure that we're not using any kind of lemon glycerine swabs. We are going to be applying water-soluble lip moisturizer as well as water-soluble lubricant for the nostrils. We are also going to be removing secretions, nasal secretions, with either a tissue or a washcloth. When cleansing the nares, we are going to be using a cotton swab, and if it isn't encrusted on the inside, we would use hydrogen peroxide followed by water. We're always going to be assessing and making sure that the tubing and the tape is in place. For administering medication through the nasogastric tubing, we are first going to be following generic medication administration guidelines. If we are going to be distributing a multi-dose, then we are going to make sure that we have the correct amount. We're going to be ensuring that we are able to crush or mix the medication. With liquid medication, we are going to make sure that we are shaking the bottle, that we are pouring it with the label in our palm, that we are wiping any excess off the bottle. When we are measuring, we are going to be measuring at eye level and making sure that we have the proper amount. When we are to crush pills and put them in separately, we are going to be also adding 20 milliliters of water to each one. So we are going to be verifying placement before we administer medication. We are going to be aspirating stomach contents, and we will withdraw it. We would put it in and check our pH balance. Anything under 5.5 usually indicates gastric contents. We can also auscultate using our stethoscope and putting air through the tubing and listening with our stethoscope in the abdomen and listening to the whoosh sound. We will also be checking for residual volume. So the first thing we're going to do is we are going to insert the syringe. We're going to make sure we have the proper and correct size syringe. We're going to be taking off the plunger to the top of it here. We are going to be putting 20 to 30 milliliters of water. After we're done flushing, we are going to then start giving our medication. So here I have 3 different types of medication. First thing we're going to do is we can either do it by 2 methods. We can either pour it into the syringe and let it flow down, or we can also use our plunger to distribute it. After we are done with our giving our first medication, we are going to then flush it again with 20 to 30 milliliters of water, and then we would give our next medication, flush it again, give our third medication, and make sure that we are flushing it when we are all finished up. When we are done, we are going to have the patient sit up in high collars for about a half hour. We are not going to attach the suction device for another half hour, or for a half hour as well.